I waited 2 years and 10 days. Then they called my house and I answered the phone and they explained that the donor was a young man who had been in a car accident. I just burst into tears.
For the 23 years that he was on this earth, by being an organ donor, he is still here and helping people.
It's a pretty shocking thing to know that your life or death is dependent upon getting an organ to live your life. The role of Gift of Life Donor Program is to make sure that every family who loses a loved one has the opportunity to say yes to organ and tissue donation. And in turn, what we do is match those organs with the most needy recipients to be able to save and enhance lives.
We were connected with Gift of Life when we learned that Anthony had really no hope of recovery. They shepherded us through the process of the preparation of getting to the operating room where we had our final moments with our son. A group of 20 of us gathered around my son in prayer as we watched him pass.
We're that bridge, if you will, between the death of somebody and their donation. Our transplant coordinators, our frontline staff are interacting with hospitals and families at their very worst times.
The scariest part of the organ transplantation process is the waiting. There were years where I wondered, why was I still alive? To suffer and to endure everything that I was going through. And my daughter was born, and I knew. Gift of Life is an amazing partner in the transplant journey, and that's dedicated themselves to making miracles happen.
They're your first cheerleaders. They're so encouraging and so loving. And, you know, when you're going through some really hard stuff.
I never in a million years would have thought that I would be using my arms again because of a family that decided to participate in tissue donation. For me, the Gift of Life just means gratitude.
I lost my son because God was ready, but I said yes to organ donation. Knowing that my son was able to save 3 young men's lives, that makes me smile. So instead of me being in a dark place, I'm in a good place because I know what I did saved lives.
If it were you on the waiting list, if you had a chance to save your life by accepting a donated organ from someone else, if it was your child and they needed an organ to survive, would you accept an organ from someone else? If your answer is yes, then you have to put yourself on the registry. You have to do it.
Our vision at Gift of Life is that anyone who needs a transplant will get a transplant and not die waiting.
My name is Oni Kanai.
My name is Derek Fitzgerald.
My name is Arlinda Griffin.
My name is Stephanie Maria Tensia.
My name is Joe Pratt.
My name is Carrie Daly.
I'm Reverend James Burton. I received the Gift of Life.
And I received the Gift of Life.
Good evening, everybody, and welcome to Understanding the Organ Donation and Transplant System, How and When Will I Get My Gift? I'm Howard Nathan, President and CEO of Gift of Life Donor Program, and we welcome you to this webinar, and we hope that you'll take an active role in asking questions in the Q&A. Next. Next slide, please. So a little housekeeping. I'm sure that many of you are used to Zoom meetings. You should know that all attendees are muted, but you should be able to hear us. Your camera will be off and your video will not be shown. The slides of videos will be shown during the program, so we'll watch for that. But use the Q&A button down below. You can submit questions at any time, and Todd will read some of the questions to us publicly. If you want something that's private, then you can target that to us later. Next slide. So who is Gift of Life Donor Program? Well, Gift of Life is located in Center City, Philadelphia, and we're a nonprofit organization called an organ procurement organization. And we perform organ recovery, tissue recovery, and also we have an eye bag for cornea recovery. We were established in 1974, and we're the largest organ procurement organization in the United States. And I'll show you some information about that. We're federally designated by CMS, which is the Center for Medicare and Medicaid Services, which is the federal government, for the eastern half of Pennsylvania, southern New Jersey, and Delaware. There are 128 hospitals in our system, 15 transplant centers, and 40 different organ programs, and an 11 million population. We're accredited by numerous organizations that I won't bore you with the details, but we're an accredited organization with the National Network of the United Network for Organ Sharing. Next slide. So you're probably waiting at one of these transplant hospitals that are listed here. And these are the 15 transplant centers that serve our population in our region. And there are different organ programs at each center. So some centers perform only kidney transplants. Some centers perform kidney, liver, heart, lung, and other transplants, pancreas transplants. But you're at one of these centers and your name is on the waiting list at one of these hospitals. Next slide. What is Gift of Life? So Gift of Life, the primary services is to be on call 24 hours a day so that our coordinators can respond to potential organ donor situations in one of those 128 hospitals in our 3 states. We lead the discussions related to organ donation and tissue donation with the families who just recently lost a loved one. And we coordinate an authorization process, or if the person had it on their driver's license, we can act on that. We coordinate the surgical recovery of the organs and tissues, and we allocate the organs according to national guidelines called United Network for Organ Sharing Guidelines. We provide comprehensive bereavement care for all of our families who give the gift of life, assist with the development of policies and procedures, particularly with hospitals, and we provide a lot of professional and public education, along with our ambassadors who help us do a lot of education in our community. Next slide. So we're very proud that our region is the most generous community in the nation for the past 13 years. And just last year, there were 619 organ donors that resulted in 1,619 organs transplanted. There were also 1,385 people who gave the gift of tissue, which is such as corneas and bone and skin for burn victims. Also, cornea transplants is listed here separately. And also we have the 4,300 nights of service of our Gift of Life Family House, which is a home away from home that families who come to Philadelphia who's coming for transplant to one of the city hospitals can stay there. And we'll tell you more about that. Next. This is our track record over time. You can see that it's going up over time, except for last year where we slightly had a small dip, primarily because of the COVID pandemic. But this is a good track record. And as I said, the largest in the nation for 13 years. Next slide. This is the number of people and organs that have been coordinated for transplant over our 46-year history. Over 53,000 organs have been coordinated since 1974, and this shows up until 2020. And of course, this year, the first 2 months of the year, put us over 53,000 organs coordinated for transplant. You can see that most of those are kidney transplants. The second most is liver transplants, then heart transplants, lung transplants, pancreas, and small bowel transplants. So you're in a good place. Next slide. This is the number of people waiting on the national list, 107,941. But regionally, there are 5,108 people waiting for a transplant as of today. You can see that most of the people waiting are kidney patients, 4,491 people, 360 people waiting for livers, 104 waiting for lung, 110 waiting for heart, etc. So you're on this list waiting for a transplant. Next slide. So what did we do when the pandemic hit? We actually went into action and made sure that no potential organ donor and no gift of an organ or tissue was declined. We basically began implementing testing for those donors with COVID testing. And we make sure that every single organ that is, every single donor and every organ that's transplanted, that those patients get a safe organ. At this time, COVID-19 testing is done in such a way that no one receives a test, no one receives a positive organ. So that means that every time we have a donor, we perform this test before the organ is taken out so that it's safe. We've adapted a lot of different procedures, particularly with hospitals and our donor families. You know that there was restrictions for hospitals initially with not having families at the bedside. So some of the conversations that we had with our families were actually done by Zoom or Skype. We secured PPE for our frontline staff to make them safe. And we did a lot of things in the hospitals to help make sure that we thanked the people who were caring for loved ones in the hospital and made sure that because of their cooperation with us, partnerships every single day, we provided care packages, meals, and we even provided ventilators to support coronavirus patients. Next slide. So how does the system work? So we're going to play another video now that'll explain a little bit about the national system. It's a cartoon-like thing, but listen to the narration. It tells the story of how the process works.
Every year, many thousands of people receive the gift of life, a life-saving transplant of a heart, kidney, liver, lungs, pancreas, or intestines. And thousands more people receive corneas and other tissues that restore sight and health. Transplantation is one of the great medical advances of our time. How does it work? It all starts when someone's organ begins to fail, and that person will need a transplant to survive. A thorough evaluation is conducted at a transplant center, and if the person's a good candidate for a transplant, he or she will be put on the National Transplant Waiting List. Once a person is on the list, the wait for an organ begins. A national system matches people on the waiting list with donors. The factors considered in matching donors and recipients include blood type and body size, how sick the patient is, distance from the donor, tissue type, and length of time on the waiting list. What doesn't get taken into account? Organs are never matched based on race or gender. Income, celebrity, and social status are also never considered in matching donor organs to waiting patients. There's no telling how long the wait will take. In fact, some people don't receive an organ in time because the waiting list is very long and there aren't enough donors available. That's why an average of 20 people on the waiting list die each day. Imagine how many we could save if we all were donors. Most organs for transplants come from deceased donors. Here's how that happens. A person comes to the hospital with a life-threatening brain injury, such as from an accident, a stroke, or lack of oxygen. The doctors work hard to save the patient's life, but sometimes nothing can be done. There's a complete, irreversible loss of brain function. The patient is clinically and legally dead. That's when being a donor can turn a time of loss into a time of hope. Because machines have kept blood containing oxygen flowing to the organs, they can be passed along. One person can give life to as many as 8 people through organ donation and enhance the lives of 50 people or more through eye and tissue donation. But now, minutes matter. Matches must be found, and transplants must happen quickly. The hospital contacts an organ procurement organization, an OPO. OPOs manage the organ recovery process. The OPO checks the state organ donor registry. If the person is already registered as a donor, they'll inform the family. If not, they'll ask the family to authorize donation. A medical examination takes place. They check the medical and social history, and if the person is eligible to be an organ donor, the computer begins the search on the national waiting list for well-matched patients. The best matched patients for each organ are contacted by their transplant teams. This is the call that every single person on the waiting list has been hoping for. The call that could mean a second chance at life. Now the transplant happens. A surgical team recovers the organs, then corneas and other tissues. The organs are sent to the transplant hospitals where the patients and transplant teams are waiting, and the life-saving transplants take place. It will take healthy living and medications to keep the organ working well in its new home. But some wonderful person has given the most precious gift of all, the gift of life. You too can make the decision today to sign up on your state registry as an organ, eye, and tissue donor. Any age is the right age, young or old. And any day is the right day to sign up as a donor. You can register through your driver's license office, or you can sign up right now, online. Remember to tell your family so they can support your wishes. More than 145 million people have already signed up, but we're all needed to save more lives. Go to organdonor.gov and sign up in your state donor registry as an organ, eye, and tissue donor. Go to organdonor.gov and share the gift of life.
So that's a video from the Division of Organ Transplantation in our federal government. And I hope that it gave you a synopsis of what we're going to talk about tonight. Next slide. So one of the hubs of the wheel of the whole system is our Transplant Information Center. This is where all the calls come in from the hospitals where there's potential donors, in addition to organs that might be available from other cities that don't match their patients, but match ours. So I'm going to introduce Larry Suplee, who's the director of the Transplant Information Center here at Gift of Life. Larry?
Hi, good evening, everyone. Thank you, Howard. So as Howard said, I'm the director of the Transplant Information Center here at Gift of Life, and our team coordinates organ allocation from deceased donors to transplant centers and patients. It's really an honor to speak to all of you this evening. You're an audience that I don't too often get the opportunity to speak in front of, and as Howard mentioned in the opening video, you know, all of you are why we do what we do, and as Howard said, our goal is to make sure every person who needs an organ gets one. Tonight, in about 15 minutes, I'm going to share a whole lot of information that would probably take hours if the webinar was that long to get through, but really give you some high-level information about what happens here at Gift of Life and in the donor hospitals and how the organ donation process works. Next slide, please. So we know it starts with a call from the hospital. We have close to 130 hospitals in our service area that call us when they have a potential donor. Potential organ donors are typically in intensive care units. They're on a ventilator, and they've suffered some sort of non-recoverable brain injury. As a condition for CMS, every acute care hospital has to have a relationship with and refer potential donors to an organ procurement organization. You'll hear me say OPO throughout the talk. Next slide. So here's the map nationally. In addition to Gift of Life, there are 56 other organ procurement organizations that cover designated territories. These OPOs range in size from very large like ourselves and out in Los Angeles to much smaller OPOs out in the Midwest. But this network really makes sure that every acute care hospital is addressed, and that we have relationships with all those hospitals to make sure every donation opportunity is realized. Next slide. So who can be a donor? Well, to start with, almost anyone. But the reality is we typically don't know how or when we're going to die. And what makes organ donation such a rare occurrence is organ donors suffer a non-survivable injury or insult to their brain. And this could be from a head injury or trauma, a stroke, a cardiac arrest that resulted in lack of oxygen to the brain. Of all the deaths in hospitals, only 1 or 2% have that potential to go on to become organ donors. And again, this is from our intensive care units. They're on a ventilator that's really keeping their body oxygenated and giving blood and oxygen to the organs. Hospitals don't call us until all life-saving efforts have been exhausted, or the family asks us that no further interventions are performed. Only then will a hospital call us, and then we can begin our evaluation process. Next slide. So once we're made aware of a potential donor, we'll complete an initial evaluation over the telephone, and then we'll send a transplant coordinator out to the hospital. And given the nature of our work, our coordinators are typically nurses or paramedics that have extensive critical care or emergency medical experience. Once we arrive at the hospital, we'll start partnering with the healthcare team to begin our evaluation. It's that point very early on that we'll access the donation registry to see if that patient had already made the decision to become an organ donor upon their death. And then when appropriate, we'll meet with the family to discuss donation. If the patient is not donor designated, then we'll seek authorization from the family. And we do this in a respectful and compassionate manner. We work closely with the hospital staff to have this conversation with families. And we take a lot of pride in both the care we provide for donors and their families, as well as the relationships we've built with the hospital staff over the years. Once we have that authorization for donation, we'll then begin to manage the donor, and that entire donation and matching process that I'm going to talk about will begin. As you'll see in the upcoming slides, this is a really complicated process. Could take anywhere from 36 hours or more to complete. Next slide. So our donor evaluation process. We want to make sure we pursue every potential donation opportunity and then safely make as many organs available for transplant as possible. So we gather all this information so that transplant teams can make the best decisions for their potential recipients. And we want to make sure the right organ's accepted for the right patient. Part of this evaluation can include tests similar to what you and I may have had done. Measure things like electrolytes, blood counts, glucose, or a urinalysis. We do an interview with the family. It's called a medical social history interview, where we'll collect information about the donor's medical and social history. If any of you out there have been blood donors and you think about the questionnaire you fill out before you donate blood, about your own medical and social history and behavior, it's a questionnaire that's very similar to that. And then we also do a complete review of the donor's hospital record. We also do a head-to-toe physical assessment of the donor and make sure any findings we discover match the information we have, and then we'll seek out additional information as needed. So for example, if we discover a surgical scar or something unusual that's not in the hospital record or mentioned by the family, we'll certainly start to look at other sources to figure out the cause of that. Next slide. So we rely on the donor hospital to do a lot of the testing and evaluation, but we work with our own lab, and that's pictured here, to complete a lot of the more critical and highly regulated testing. So every organ donor will send blood and other specimens from the donor hospital to our own lab. And before we begin placing organs, we'll test the donor for infectious diseases like hepatitis B or C, HIV. We can certainly transplant organs from donors with hepatitis, but only in the recipients who have agreed to receive such an organ. We also do tissue or HLA typing to help match donors and recipients. And this tissue typing is most often used in matching donor kidneys and pancreas with patients. But that's information can also be helpful for any patient needing any organ, particularly if they're highly sensitized and really hard to match with a donor organ. During the organ recovery, we'll also collect samples for microbiology studies or cultures. And then we'll share this information with transplant centers to make sure recipients are given the right antibiotic coverage in the days and weeks after transplant. Next slide, please. So the donor management piece is really an important part of this. And as stewards of these gifts that are so generously donated by the donor and their family, and then certainly as advocates waiting for those waiting for transplant, we have to do everything we can to optimize organ function in preparation of transplant. So a lot of that includes working through some of the challenges listed here that are all really common at the end of life, and if not addressed, can really have a negative effect on organ function and even whether or not we're able to transplant a particular organ. So that's where that critical care experience comes in from our staff. That's where a lot of the partnerships and relationships that we have with the donor hospitals and really helping to care for the donor efficiently and safely. Next slide. So if you've been on your transplant journey for a while now, or even just new to it, you probably have already heard of UNOS. That's the United Network for Organ Sharing. Those are the policies that really tell us how organs are allocated to recipients. And the UNOS database takes information about the donor and matches it with potential recipients or those that are waiting for a transplant. The system will generate, we call it a match run. More commonly, you may have heard it called a list for each organ that we try to transplant. We try to place for transplant. Next slide. So when we have a donor, we'll enter all of our donor information into the system. And when transplant patients are listed for transplant, that's when the transplant centers will list information about their candidates. So when we have a donor, we enter all that information. The system's going to take all that donor information and then give us a list of potential recipients who appear to be compatible for organs from a particular donor. And this is an important piece. A lot of times in passing, when you hear about a list for an organ, we just think of one static list where when a heart's available, patient number 1 gets it and patient number 2 moves up 1 point. Every match run is really different and very unique to the donor based upon a lot of the things we'll talk about later and location. So every list will look a little different depending upon the donor. Next slide, please. So through UNOS, we use a system called DonorNet to make organ offers to transplant centers. And how that works is the transplant team will receive an electronic notification and an automated phone call. It'll direct them to log into the system. Once logged in, they can see the match run with their patients and then all the available donor information. They'll have 1 hour to make their decision. They can enter what's called a provisional yes. And that tells us here at the OPO that, hey, this center is interested for this patient. We'll pick the phone up, call them, talk more about the donor and logistics and make sure they have all the information they need to start mobilizing their potential recipients. If it's an organ offer that they don't think is appropriate for any of their patients or some of their patients, they can enter a refusal in for 1 or more patients. And this process saves time. It cuts down on phone calls. And it really allows us to work more efficiently and quickly so that we find centers and patients who would accept the organ. The other piece, these electronic offers and responses also add a layer of transparency to the allocation process. Next slide. So we talked earlier about that extensive evaluation process and completing tests and collecting information from a lot of different sources. That's everything that goes into DonorNet. And that's really where the matching process starts. So if you look at this slide, for example, the donor age and blood type are 2 of the biggest factors. However, you'll see in a few minutes, a lot of that other information is really important in helping the teams make decisions. Next slide. So here are some of the factors that go into that donor and recipient matching process. Some of these will determine whether or not you appear on a match run for a particular donor. Some of the other information is going to help your transplant team make decisions about which one of their patients might be appropriate for that particular organ. For example, height of the donor. That's important for matching donated lungs. Usually the donor and recipient have to be of similar height, give or take a few inches. If the organ donor has hepatitis C, we're only going to see potential patients on the match run who've agreed to or can receive organs from a donor with hepatitis C. And then there's laboratory studies. So if a transplant team's evaluating a kidney offer, they're going to look at labs related to the donor's kidney function to see if they believe that to be an appropriate kidney for one or more of their patients. And then we'll do cardiac and pulmonary testing, like cardiac catheterizations, bronchoscopies, to help us assess heart or lung function of the donor. Additionally, tests like CAT scans and chest x-rays will give us a wealth of information. And then as Howard mentioned, we also test every donor for COVID-19. Next slide, please. So this is a common question we get, so we have a slide for it. Here's where you can see how long each organ is viable outside the body. The length of time here might vary by surgeon or belief in how long that can be. But this time between organ recovery from the donor and transplant is what we call cold ischemic time. You'll see up here, the heart is most susceptible to that impact of cold ischemic time, 6 to 8 hours. And even that may feel a little long for some centers. Whereas the kidneys can go up to 36 hours or longer between that donor recovery and transplant. So you'll come to learn deceased donor kidneys get shipped all over the country with some of the sharing and some of the policy requirements, particularly for hard to match patients. Next slide. A great resource that we have are different types of organ preservation machines. So these machines allow us to assess and then in some cases improve organ function. They also allow the organs to remain outside the body much longer. So lungs, for example, when lungs are placed on one of these machines, we can make interventions to optimize function and lead to a better transplant outcome. So we can do donor management interventions just like we would if the lungs were still on the donor, yet they're on the machine to really make them better and provide the transplant team with more information. Kidneys are the most common organ that's placed on preservation. And when kidneys are on the pump, and that's, if you look at the slide on the top right, that really gives the transplant team more data to show us how well those kidneys are likely to work in a patient. Next slide. So the matching process is complicated and long, but in short, really the goal of organ transplantation and placing organs is to get the organ to the sickest person waiting the longest with an acceptable cold ischemic time for each organ, and then in the most equitable manner possible. So organs are allocated using fixed distance circles around a donor hospital. Most often these circles are either 250 or 500 nautical miles. And then depending on status, organs for the most part are offered to transplant centers and patients within that circle first. There are times where critically ill patients outside that circle may get the first opportunity at a particular organ. Hearts are determined by status, so there are different statuses for heart patients based upon their medical need. And then donor hospital distance is also factored in. For lungs, there's something called a lung allocation score. That's driven by the potential recipient's medical urgency and need. Waiting time is also a factor, and then again, distance from the hospital. Livers are determined by medical need, or if you're a liver patient or a family member, you've heard the term MELD score. So the higher the MELD score, the higher you appear on the list. Kidney and pancreas, they're determined by waiting time, and then some of that tissue matching between the donor and the recipient. Proximity points, meaning how close you are between the donor hospital and the transplant center. And then for certain kidneys, what's called survival benefit. So in terms of how long that kidney would be predicted to last in a particular patient. Also of note, prior living donor. So if someone has given a kidney to someone else and then later in life goes into kidney failure, those patients are given priority on the list. And then pediatric candidates are also given additional consideration. This is really a short overview of this. I know in April, we're going to be doing a similar webinar with a little more time to talk about this through the Family House. You'll get more information on that a little bit later. Next slide. So here we can see what 250 nautical miles looks like around Philadelphia. You can see we go way out into the ocean. There's no donors and there's no transplant centers in the ocean. Our donor hospital is always going to be at the center. So this circle is going to move with the donor hospital. You can see here there are 63 kidney transplant centers and 23,000 kidney patients waiting. On average in this circle, there are 6 or 7 deceased donors per day. So anywhere from 12 to 14 kidneys that are offered out for transplant. The number of patients waiting within a circle are going to vary throughout the country. One of the challenges here in this part of the country is we're one of the most populated areas of the country. So our circle is going to have a lot more patients, a lot more people, and a lot more transplant centers. But we're also going to have more organ donors. Next slide. So in order to move surgical teams and donated organs to and from the donor hospital, the transplant center, we have to rely on an extensive network of transportation providers. This includes transportation teams that specialize in donation and transplant. We'll use medical helicopters, private jet charters, ground couriers, and then we also have our own fleet of vehicles that on certain occasions our team will drive. You heard me talk earlier about kidney sharing and putting kidneys, sending kidneys all over the country. We'll use little GPS trackers that we put with the kidney to accompany that organ if it's going to be unattended or traveling without a member of the transplant team. So if it's a courier in a commercial airline moving that kidney for us, we'll have a tracker on it so that we can follow it every step of the way. Next slide. So I'll talk for a moment on the next 2 slides, really about some of the many reasons you could be called for a transplant that doesn't happen. And through that donation process, there are so many factors taken into consideration as an organ donor moves from one phase to the next, and more information becomes available. It's often this new information that's going to impact the center's ability or decision to accept an organ for a specific patient, or in some cases, all their patients. In fact, it's actually really common for a liver or kidney to go to a patient further down the match run and not that intended patient identified prior to the recovery of the organ. A potential kidney recipient might have a positive cross-match with the donor, so when they take some of the donor blood with the potential recipient blood and determine that they're not a compatible match, they're incompatible and can't receive the organ. When we're in the donor operating room, the size of the actual organ may not be appropriate for the intended patient. There could be anatomical findings or findings with the arteries and veins like hard plaque that might impact that final acceptance decision by a team. And all that information becomes available throughout the process all the way through to the end of the operating room. And that's where we have to share that with transplant teams to make sure they have all the information and are making the right decision. Next slide. So we know all these unexpected challenges occur, and we've learned to plan for them. Then recognizing the limited opportunity we have to place an organ, we have to work with transplant centers to identify and mobilize several recipients really for each organ. You may hear the term primary and backup. It's really our role to be prepared for every possible scenario to make sure every donated organ is transplanted. I covered a whole lot of stuff in a short period of time. I know in a couple of minutes, Talia is going to talk about a webinar we're going to have in April, where we can spend more time on different parts of the process. With that, I wish you all the very best on your transplant journey. I know many of you are waiting for that call, and we certainly hope that comes for you very soon. I know I'll have time at the end to answer questions. It's now my pleasure to introduce you to our next speaker. Talia Giordano is our Family Services Manager. So I'll hand things over to Talia. Thank you, everyone.
Thanks, Larry. Welcome, everyone. I'm really excited to talk to you today. So really quickly, before we get to introducing our panelists or our patient and caregiver tonight, I'm going to talk really quickly about the Family House as a resource for patients and families who live outside of Philadelphia but are traveling into Philly for their transplant treatment. So we provide lodging and supportive services to transplant patients and family during any stage of the transplant process. So this includes during their evaluation. So if you're a patient and you're not yet listed, but you're going through the evaluation to be listed, you and your caregiver can stay with us. This also includes any other pre-transplant appointments, as well as any post-transplant appointments for the rest of your life after your transplant. And then during the transplant surgery or any other transplant-related hospitalization, your family can stay with us. We provide nightly meals as well as support with transportation to and from any of the transplant hospitals. We also offer counseling and additional resources to families that stay. And then one of the most significant benefits is really having access to other patients and families who are also staying and going through a similar process. So it's a really great resource to be able to share stories, to support one another, and just to learn about each other's journeys. It's $40 a night, and that includes all of our amenities and resources. However, no family will be turned away for their inability to pay. We're actually coming up on our 10th anniversary, so we've been operating now for 10 years, which is really exciting. And we maintained our operations throughout COVID. So we initiated some practices to make sure that everyone was safe, and we were doing what we could to keep people safe while they were here for their transplant treatment. So if you are a patient or a family who live outside of Philadelphia but are coming into Philly for your transplant treatment and you would like to reach out about staying, you can visit our website or give us a call. So now I am going to introduce our panelists. So we have a transplant patient, 2 transplant patients or recipients, and a caregiver. So if Ashley and Timmy, if you're able to turn your cameras on, we're going to talk to them a little bit about their transplant journey. So I do want to preface this with, this is their transplant journey. It's their very specific transplant story. If you have any questions or concerns about your medical or transplant journey, it's very important that you reach out to your transplant center or your transplant team directly. So we're going to start with Ashley and Bobby and their 2 beautiful daughters. So they're going to do their best in answering while they have their 2 little girls with them. Thank you guys so much for being here, Ashley and Bobby, and Amara and Maisie. So Ashley is the caregiver and wife of Bobby. He had a lung transplant almost 6 years ago, which is so exciting. He'll be celebrating his 6-year anniversary next month. Ashley also stayed at the Family House during her transplant treatment, and they're going to talk more about their story. So we're going to start with Ashley. Can you share a little bit about what led to Bobby's transplant?
Yes, can you hear me?
Yes.
Okay. So Bobby was, he was very healthy and we were living our normal lives, and he became unexpectedly ill and was hospitalized and diagnosed with pneumonia, and they think, but not confirmed, that was caused by the flu. And he was intubated very quickly after he was hospitalized, and he was in a drug-induced coma for about a month and a half. And so we sorry, I'm a little distracted with the baby. Okay, Bobby's got her. Okay, sorry about that. So he was hospitalized. He was in a drug-induced coma. He was on a ventilator. He required ECMO, which is basically like an artificial lung. It oxygenates the blood when the body can't do it. And it was ultimately determined that if he was going to survive, that he needed a lung transplant.
So can you tell us about like when the call came, or the call, because he was in the hospital at the time?
Yeah, so once they were able to finally wake him up from the drug-induced coma so that they could do the proper assessment to list him for transplant, he was awake for a couple weeks, and then we decided that we were going to move up our wedding, and we decided to get married in the hospital. And it was actually, we were getting married actually 2 days after he was finally listed for transplant. And before the wedding ceremony, the doctors came in and told us that they had a prospective donor for Bobby right before we got married.
That's amazing. And now you can never forget the transplant anniversary or your wedding date.
Right.
So can you tell us a little bit about like what the recovery was like for him in the hospital?
Yeah, bless you. So recovery was very tough because Bobby was so critically ill. He had to relearn how to walk, talk, swallow, speak, everything. So recovery was very challenging in our circumstance. But post-transplant, he was there like about another month and a half until he was discharged home. So it was tough, but he moved along and he progressed well after he received his transplant. And it was not soon after where he didn't need assistance, breathing, because his donor lungs were working well and everything was going well.
Mommy, push me.
And then at what point was he discharged, and what was the recovery like at home?
So he was discharged actually just shortly before his 34th birthday, which was amazing to be able to be home for his birthday. And I'm sorry, you said what was it like when we got home? Mm-hmm. So, it was absolutely relieving to be home after having been in the hospital for several months. But, it was an adjustment, getting used to how to manage things like visiting. He had visiting nurses for a while, getting to appointments, follow-ups at the hospital, figuring out medications, brand names, drug names, how we were gonna make that all happen logistically, mail order, go to the pharmacy, he was on so many medications. We were going to the pharmacy like every day. We were like, we better get this through the mail because this isn't working out. So just figuring things out logistically once he was home, it was challenging, but it was doable, and we were happy to do it and figure it and be able to have that as a problem to figure out versus what we were dealing with before. So
yeah, of course. So before we have Bobby, if he's available, to just answer one or two questions, if you could tell any caregiver who's like new to the transplant process, what would you tell them?
I would tell them to seek support as as quickly as you feel comfortable doing that, whether it's through family and friends that you feel most supported by, whether it's through online support groups, especially now during COVID. It's really helpful to just know that other people are going through similar things that you are, and to get that support. And also, if you're comfortable with it, seeking out a professional therapist, I think is a great idea too, to help you work through the challenges that come up. And then other than that, I would say, it's important to advocate for your loved one and also for yourself, and make sure you're getting what you need to.
Yeah, great. Thank you so much, Ashley. So Bobby, before we talk to Timmy, I think most importantly, it's been 6 years. So how are you doing now, and how have you managed the last year?
I've been feeling really well. I think I'm living a normal life, as normal as it can be after transplant. And it's with the exception of taking meds every day, it's a fully normal life. I feel good. We have a beautiful family now. We were able to have 2 daughters after the transplant. And, I've been working since a year after the transplant. I'm still working full time. Everything is good.
Great. Thank you so much, Bobby. And I just want to mention that you guys you've had those 2 daughters after your transplant, which is just so amazing. And, if it weren't for a donor, who helped with that. So thank you so much, Bobby. We're going to have you stick around just a little bit longer for the Q&A section. So now I'm going to introduce Timmy. So thanks so much, Timmy, for being with us today. So Timmy had a little bit of a different transplant experience. He received his kidney transplant in July of 2017. So he's coming up on 4 years now. And he had a bit longer of a wait for transplant. So Timmy, can you tell us what led to your kidney failure and transplant?
Tell you, that's one of those mysteries, to be honest with you. I was very healthy. No issues, no concerns. I went to the hospital to have a back surgery, a nagging issue I had for years, took care of that, and ended up staying a couple more days because they discovered that my kidneys were failing, but I had no symptoms. Later on, I found out that I have a few folks in my family that had the same kind of issue. So something hereditary in my line, I guess. I went in, that was January of 2013. I went in for my back surgery, found out I had kidney disease. In July of that year, in December of that year, I started peritoneal dialysis, did that for 3.5 years until I got the opportunity to have a transplant in July of 2017.
Okay, thank you. So when did you actually get listed for a transplant?
When I went on dialysis in December of 2013, my nephrologist and the dialysis facility talked to me about the waitlisting process. So I made a point right then to do everything I could to get waitlisted. And so I was waitlisted that following April. So right away, I made sure that happened.
Yeah. And so you waited for 3.5 years, which I'm sure feels like a very long time when you're on dialysis, waiting for the call. So how did you manage that?
You know what? I think it's acceptance, and it's not easy. Don't get me wrong, but it's acceptance. I think it's a matter of saying, this is the hand I'm dealt. I have to play it, and I had a choice. In fact, one of my nurses told me, she says, I can only teach you, and I can only instruct you, I can only coach you. She said, but how it works out for you, it's really going to be up to you. And so I made a decision that this is the hand I'm dealt with. I'm going to play it the best I can. And I made the best out of it. I did all the things I was supposed to do. I followed all the instructions. My doctor said, do it. I did it. And the questions I had were to learn, not to challenge.
Okay, great. Thank you. So can you tell us what it was like when you got the call?
A bit shocked at first, to be honest with you. I actually came in about 6 months earlier. I was told I had about a 4-year wait time, but it's actually about 3.5 years, which 6 months is a long time to me, But anyway, I got the phone call and I was told I was number 4 in line for this kidney. So then my thought was, there's no way anyone's going to turn down a kidney. Well, after a series of 10 to 12-hour increment phone calls, I was told to get to the transplant center because the kidney was mine, and I did not hesitate to go to get that transplant. Went there, and they actually did it that evening. I went in and got prepped right away. They did it that evening, woke up the next day, and later that afternoon, I guess, and had a new kidney. Yeah.
And you actually, I remember you woke up on your birthday, right?
That's exactly right. Best birthday gift ever. I went in on the 21st of July, and when I woke up on the 22nd of July, it was my 60th birthday.
So you also will never forget your kidney transplant.
That is for sure.
anniversary.
That is for sure.
That's amazing. So can you share a little bit about what your recovery was like?
You know, the day after I had my transplant, my doctor came in and he said, "You need to start walking." And my first thought was, "You got to be out of your mind." I got an incision across my abdomen that's so many inches long. How am I going to walk now? He said, "It'll be difficult first, but you have to start doing that." And he explained to me, he says, we can coach you, we can counsel, we can give you medication, but the body also will heal itself if you allow it to do so. And so, frankly, I started walking then, and I was reminded, walk only as far as you can because you got to go back. But I haven't stopped. And I tell you what, it's become a mainstay of my life since then. So almost 4 years, I have a daily regimen of walking.
Great. And how about, like Bobby and Ashley had mentioned, like you had a whole new medication regimen and appointment schedule. So how was that?
Yeah. Now, when I was on dialysis, I had a number of medications I took also. The encouraging thing about these medications that these medications are on the recovery side, not the illness side. So yeah, I take immunosuppressants, tacrolimus, prednisone, those kind of things, just to make sure that my body doesn't reject the kidney. I have a daily regimen of doing it. It's like clockwork in my head. At 9 o'clock and 9 o'clock, I take my medications, and has not been an issue because I was taking medication before. I'm taking a lot less now than I was before. So.
And can you tell us how you're doing now?
I'm loving life again. I am very active. I retired just prior to my transplant. But I tell you what, most people say, you never retire, you just kind of start working for free. I do a lot of volunteer work. I'm on a lot of boards in the area. I stay very, very active. I'm an avid person at the gym. I'm there 3 days a week. So I tell you what, I'm taking advantage of this opportunity to have a good, fulfilling life.
Thank you. So my last question is, if you could, what would you tell someone who is new to the transplant process? So they're feeling overwhelmed and uncertain, what would you tell them?
It's difficult because I think the average person is going to feel like, why me? Why did this happen to me? And my response to them would be, well, it did happen. So let's talk about what you need to do to make sure this transplant stays the course for you. And that means listening to your doctor. That means doing everything you're told to do with no exception. That means taking your medication. That means being as healthy as possible. That means eating right. That means all the things that your doctor and your dietitian and the medical staff are going to tell you, you have to do those things. Because if you don't, you could end up in a worse situation.
Yeah, for sure. And I actually have one more question since we have a few more seconds. Did you communicate or write to your donor family?
I did. That was challenging, but also inspiring. Because my donor was a 20-year-old that just, her brain stopped. We have shared letters, and I've learned a lot about Gwen. She's a beautiful soul, just based on the letters I've received from her family. I do look forward to meeting her family one day if they feel up to that, with great anticipation, though, because the only testimony I can offer them is that with Gwendolyn's support, we're doing some good work, and that's why I think it's one of the reasons I volunteer a lot too, because I owe people a lot of things, and I owe a lot because of this, and my job is to give back.
Great, thank you so much, Timmy. So in ending this panel, I just want to highlight that the transplant process can look very different for everyone. So if you are looking for resources or need additional support, you can reach out to your medical team or your transplant team, and we'll talk a little bit more about other resources that we provide for patients and families. So Howard, thanks for coming back. So I think this is an opportunity for questions from people.
Yeah, I just want to thank Bobby and Ashley and the kids and Timmy. Wow, I'm like going, yeah. Thank you for doing that. Appreciate the testimony. It's good to see. I haven't seen Bobby in a couple years, so Bobby, good to see you.
Good to see you too, and thank you.
Yeah. Well, stay on. You guys stay on. Maybe there's something, the questions will come up. So Todd's going to be the voice of God and read the questions from the chat.
Okay.
Todd? Yeah.
Okay, everybody, we've got some good questions. Again, if you have a question, please put it in the Q&A little bubble at the bottom, and we'll do our best to answer it for you. So to get started, can you talk a little bit about getting listed at a transplant center that's outside of this region? So what's maybe referred to as being double listed at two different places.
So the answer is yes. Not many people do it. It depends on what organ you're waiting for. So, if someone's waiting for a kidney, for example, it's not unusual for someone, let's say, that is from New York, and they go to the Florida in winter and be double listed in Florida. But the answer is yes, the UNO system allows double listing with more expanded sharing of organs within regions. It doesn't necessarily help to get it faster per se, but the system does permit it. And the way you do it is you talk to your transplant team, and they have to send your records to the other center that you're selecting. I'll just say that there's a great resource online. It's called srtr.org. Every single transplant center is there in terms of the number of transplants they perform by organ and the outcomes in terms of the organ survival, the patient survival, and how long on average people wait for each organ at that particular center. It's a great public resource.
Okay, thank you, Howard. Can you talk a little bit, can someone answer about if there's an age limit to getting listed for or receiving an organ transplant?
Not really. Larry, you might help me with this. No, there are people who are waiting for organs who are in their 70s. I've even heard of a patient who's 80 years old who got a kidney transplant. It really depends on your physicians and your centers to determine whether you're suitable, not just by age, but medically suitable to get a transplant. And so that's really a medical decision done by the transplant hospitals.
Great. Talia, can you talk for a moment about if the Family House, talk about how transportation works during the pandemic, and if any other changes that have happened as a result of COVID?
Sure. So we have altered many of our services during COVID to make sure we're keeping everyone safe. First, we have limited our occupancy to half so that we can keep people spaced out. Unfortunately, we did put our volunteer services on hold, which includes our van transportation. So as a way to still support transportation for families staying, we have been subsidizing Uber for people. So people are able to request an Uber through our front desk if they're in need of transportation support, and they can be transported to their appointments. We've altered a few other services, and they're actually listed on our website. So if you're interested, you can check that out.
So,
Thanks, Talia.
Todd, I would, if people are willing to stay on, I'm willing to stay on. If folks are willing to stay on for, about 10 more minutes, we have quite a number of questions.
Yeah, so we're going to do our best to get to as many questions as we can. Again, we've had some good content and we've got some good questions in the Q&A box. So thank you. So Larry, can you maybe address a little bit, talking about some of the screening and criteria for accepting an organ, maybe from a donor that isn't perfect donor or maybe a marginal organ for transplant. Just kind of talk about the criteria that's considered.
Sure. So there's a couple different things when you talk about criteria, and one of the most straightforward ones I think has to do with if your donor is increased risk. So UNOS and the public health services define certain organ donors as what's called increased risk. And that may be for some certain behavior, certain types of drug use, or other activity. Potential candidates have to give consent at the time of listing as to whether or not they would accept a donor from an increased risk donor. And transplant centers have to walk the patients through that. And it can be complicated, and I always think of it a little bit as analysis paralysis. If you get too much information, how do you make a decision? And I know some transplant centers do a good job sort of explaining it through the lens of everyday life. So if you take an organ from this donor, you're as likely to get hepatitis as you would be to get hit by a bus on a Tuesday, to sort of put real life scenarios out there about what the level of risk might be. When we have organ donors who are older, or have a lot of comorbidities, those organs might be harder to place, and transplant centers might have to find the perfect recipient for that organ. It could be the size of the donor compared to the size of the recipient. It could be the medical history of the donor that makes that organ a little harder to find a home for than, say, someone healthy who suddenly had a traumatic death and was a lot younger.
So typically the transplant surgeon who gets the information, if they think it's in one of these categories, they probably will discuss it with the patient and the family. And that way that they're clear, even at the time of transplant, that is the risk involved. If it's not a huge risk or something, if you're like me and you're an old guy, and I'm getting a kidney that looks like me, that's 65 or older, they may mention it, they may not, and saying, well, this is a good kidney for you. But things about infectious disease, they'll probably talk about. Go ahead, Todd.
Okay, next question I'd like to ask our panelists to weigh in. Can you talk a little bit about food prep and diet post-transplant, how that has maybe changed for you guys?
Sure. Yeah, I'll start first if that's okay. Yeah, diet has certainly changed. I kind of joke around with my wife a lot because she's, we have kids recently, and I joke around with her that it's kind of like a diet that a pregnant lady has to follow. We got to stay away from undercooked meats. So, if you like medium rare burgers or steaks, you got to stay away from that stuff now. Undercooked eggs, I always liked over easy eggs. I can't eat them anymore. And, that's okay. Eat a fully fried egg now, stuff like that. So you just have to be a little bit more careful about what foods you put into your body. A lot of times they'll go over that with you. Well, I guess, all the time they'll go over that with you at the hospital, your transplant team, tell you what foods you can and can't have. There's some oddball things too, like, can't have grapefruit anymore because it negatively interacts with the medications that we take. So there are certainly some dietary restrictions, but not bad at all. certainly a small price to pay.
My case is a little bit different. I've been a vegetarian for almost 22 years now. So I didn't have to stay away from much of anything, to be honest with you. As was mentioned, grapefruit is not good for immunosuppressants, obviously. But my diet was easy for me. But it was a challenge for my dietitians because they were trying to find imaginative ways for me to prepare some meals. So a little different for me, but it worked well.
Okay, thanks, guys. Larry, can you talk a moment, if somebody is waiting for a transplant or is an organ recipient, can they possibly be a donor down the road?
Yeah, so I think, hospitals call us with every death. And we'll evaluate every referred patient to see what opportunity for donation is there, whether it's organ or tissues like eyes and corneas, skin, or bone and soft tissue. So we have had patients who have received an organ transplant. At some point down the road, they may pass away and they've become donors. And then certainly patients who are waiting should they die. Some of those have gone on to become donors as well.
Thanks, Larry. Can you, Howard, would you be able to talk a minute about, there was a mention about if there's an organ that's maybe a perfect match for outside of this region, how would that process work and what would happen?
So organs that are recovered in our region 40 years ago always typically were used in our region. However, as the system has changed, there's more sharing. So one of the things that happens is we try to get critically ill patients transplanted that are sick, and that organ may be shipped to another area like New York or Boston or Virginia. And Larry talked about these 250-mile radiuses around the donor hospital that happen. Another could happen is a perfectly matched kidney, which happens very rarely, maybe 1 or 2% of the time. Well, that kidney actually gets shared nationally. Anywhere. We've actually gotten kidneys from Hawaii, believe it or not, in time to transplant it here locally. So it's common, somewhere in the order of about 40% of the time, our organs are shared with other regions, but vice versa. Those organs from those other regions will be shared with us based on the patient who's waiting, how long they've waited, and how sick they are.
Thanks, Howard. Talia, could you talk for a moment about the letter writing process between a donor and a recipient, and in some rare instances where a donor family meets the recipients post-transplant?
Sure. So like Howard mentioned earlier, the Gift of Life Donor Program offers support to donor families through a group of professional counselors and social workers, and they also oversee the letter writing process. So if a recipient is interested in writing a letter to express their gratitude to the donor family, to their donor family, they can do so by sending it into the donor program. And then the donor program is able to access who their donor was, as well as the family of their donor, and can send it on. So it's a confidential process. Information about the donor family is not shared with the recipient and vice versa. However, if a recipient writes to a donor family or vice versa, and they continue to do so for a year through the Gift of Life, they can then elect to connect to one another, like share their contact information, and then at that point they can continue to communicate, however they'd like. So at that time, they can meet one another if they'd like. The donor program's family support services can help support that process. But the goal is that it is a safe and confidential process up till that point. We do have both our website, the Gift of Life Family House, and the donors1.org. We do have lots of resources on that process, as well as and tips on how to start that process. Additionally, the family house, we have past webinars that we've hosted that have been recorded and are on our website. So one of them is writing to the donor family. So if you're interested in learning more about that process, you can go on there. And actually, to the earlier question about food and nutrition changes, we did a webinar with a transplant dietitian as well to talk about all of those changes nutritionally that patients and families have to incorporate. So you can visit our website and see all of that information if it's something you're interested in.
Thanks, Talia. Larry, could you talk for a moment about if you can choose, if there's a deceased donor, can you choose where those organs go? In other words, can you direct where those donations go to the potential recipients?
Sure. So to an extent, the anatomical gifting laws allow something called directed donation. So, you know, if we're working with the family of a deceased donor and they know someone who's on a waiting list for a particular organ, and they give us that person's name and where they're listed for a transplant, families can directly donate to a named person on the list. You know, they can't say, I want my son's kidneys to go to Ohio, but if they know someone, they don't have to be related. They can, you know, if they know of someone waiting for an organ, they can specify and we can try to make that happen. A lot of times they're not compatible, but there are many times where, you know, that happens.
Okay, I think we're getting through most of the questions. Howard or Larry, could you please maybe address like where there's an instance where an organ is donated and then is later declined before it's transplanted, maybe by the surgical team. What would lead to that, and why would maybe some organs, what are some potential reasons why an organ would be rejected for transplant after it's been donated?
Yeah, it depends on the particular donor. So if someone, for example, in their 60s or 70s donates the organ, and then when the surgeon removes it, they notice a lot of plaque in the arteries, or they look under the microscope and there's a lot of what's called glomerulosclerosis from aging naturally, which may have worked fine in the donor, but you wouldn't necessarily want to transplant a kidney into someone that's got, you know, that type of compromise. So again, the surgeon makes that decision. And those are situations that can happen, you know, because we don't know until the organ is actually removed and looked at physically and sometimes under the microscope. There are situations where an organ gets sent to another part of the country, and as Larry said this, that the surgeon looks at it and says, you know, I'm not sure it's going to work for this patient, and then potentially they may use it in another patient that allows, you know, because as Larry said, if the kidney gets too long out of the body, it has to get transplanted. And if it's we send it to Michigan and it's already 20 hours old, a kidney, then they'll put it in somebody else. But in terms of not using a kidney, it's probably not really usable after a transplant surgeon evaluates it. I saw one thing here. People ask about how come people wait longer, certain people wait longer for kidneys. And again, it varies on the matching factors, and also, you know, if you look at the average in our region, because we're so active, you know, it's a little bit lower in time in terms of if you go to New York or Boston. So as we begin to share more often, the waiting times sometimes can be a little bit longer. And, you know, as you heard, Timmy waited 3.5 years. There have been some people who are hard to match or have antibodies in their system from blood transfusions, whatever. And it could take up to, you know, sometimes 5 or 6 years, sometimes longer for a kidney.
Thanks, Howard. Just wanted to let everybody know that after this session, we'll be sending out a survey And you'll have an opportunity to ask any additional questions that may have come up or that you thought of after the session tonight. So please look for that survey link that will be sent out along with the recording of this program tonight. So you can access that if you want to revisit some of the content tonight. Talia, just as a lead into your next slide, just wanted to talk about some of the support services that are coming up and talk about, you know, you hear often we need support after you get your transplant. Can you talk a little bit about some of the different resources that you're able to provide through the programming at the family house and some of the family support items that you've referenced?
So you could go to the next slide. And I did notice someone asked a question about that. What type of support do you need after transplant? Unfortunately, at this point, we don't offer like medical support or some of those like activities of daily living support. But for the person who asked that question, if you want to reach out to me or our other social worker directly, we can talk about what resources might be available for you guys. What we do offer is a lot of education and support resources around the emotional health of transplant patients and their families. So we do monthly education webinars. As you can see, the top listed is Larry spoke about briefly. So we're offering an extension of this program. So if you have more questions or you want to learn more about allocation and how do organs get matched, that's in April 21st. I think we actually changed it to 4 p.m. And the information about how to register will be in the follow-up email as well. So if you want to participate in that. We also offer 3 different support groups for patients and families. So we have a general transplant support group for any patient or family. We also offer a transplant caregiver support group that's just for caregivers, like Ashley had mentioned. And then for those who live in central Pennsylvania, we offer a support group for individuals who live out there or transplanted out there. Additionally, we have an online support group for caregivers through Facebook. And then our website has lots of resources and education to help families navigate the transplant process. So a lot of our past webinars are on there, articles are on there, and resources for other organizations that can help as well.
Kelly, next slide. So you may be asking, how can I get involved? We have a number of ways to get involved. One is called a volunteer ambassador, where we have folks who go out and do health fairs and speak at schools or things like that. Even those people who've been waiting have done that. Certainly people who've received the gift, and certainly some donor families do that. A speakers bureau, as we say, we help to train people on how to tell their story. Special projects and events, our annual donor dash is going to be virtual again this year, but that's something to go on our website and take a look. And next year it'll be live again. We have about 15,000 walkers and runners that come to the Philadelphia Art Museum and do the dash. National Donate Life Month is in April. There's a lot of activities. If you go to our website, donorsone.org, we'll give you that at the end. A lot of social media advocacy. I'm not good at that, but I'm sure some of you are. Religious outreach. We have National Donor Sabbath in churches and synagogues and mosques in November. And there's a lot of different materials that we can give people to communicate that to their own congregation. And we do a lot of multicultural outreach in the churches and certainly the schools. And then Talia told you about the family house. And there's a lot of volunteer opportunities there after we get past COVID. And you can go to the website and find out about those opportunities once we get past all this. So the Dash from Home is coming up in April. It's 9 days. It's a virtual event. You can participate and run or walk in your favorite place. Send us photos and text us. Includes building a spirit week for activities. A lot of different events. So go to our website, this is donor-.org. And go to that and you'll see all the different things that you can do for this another virtual dash. Next year, it'll be our 25th anniversary in person. So you come out for that. So our website's donors1.org, easy to remember. And it's also our 800 phone number, 800-donors1.org. Donors1 gets you to our front desk. I want to take this opportunity to thank our speakers. Thanks to Talia and Larry, and also our special guests, Ashley and Bobby Adams and Timmy Nelson. And behind the scenes, Kelly Anzac, Todd Franson, and our Director of Community Relations, Randy Present. Thanks everybody for attending. We hope you like this. Please fill out the survey when you get it in your email so we know what you think, and tune in to the April 24th, is it, Talia, for the next webinar on the waiting list?
21st.
April 21st. We'll send you information about it. Thanks, everybody. Good to see you. Take care.
Thanks, everyone. Take care.
For having us, guys. Have a good night.
Good night.